3 minutes past 12, you are listening to the Mid-Morning Talk on Salam Media with me, Mara Mukwanda. A prostatectomy is a difficult to pronounce word, but it's also a surgery to remove a part of a part of or the entire prostate gland. And to tell us more is urologist Dr. Salim Choonara. Assalamu alaikum wa rahmatullahi wa barakatuh, Dr. Choonara, and shukran for joining me once again.
Walaikum salam wa rahmatullahi wa barakatuh, Mariam, to you and your viewers and listeners, and thanks for having me here.
Alhamdulillah. Now, we have talked about prostate cancer before, but for those who may have not heard or seen it, please give us a recap before we can get into prostatectomy.
Okay, so the prostate gland is something only found in males. It's located just below the bladder, and prostate cancer is obviously cancer that occurs in the prostate. And often, we encourage men to have regular checks of the prostate, regular blood tests, what they call a PSA, to highlight or to decide who is potentially at risk for developing prostate cancer, who may harbor a focus of prostate cancer. And then obviously, once we find some abnormalities with their symptoms or with the way the prostate feels, or if the PSA, the blood test, is elevated, that would necessitate the patient undergoing a prostate biopsy, which then through the laboratory analysis we'll be able to make a diagnosis of yes cancer or no cancer, and that, depending on what the result would show, will effectively determine the way that patient will be managed going further.
Mm-hmm. All right, now, what is a prostatectomy, and when will it be needed?
Okay, bit of a tongue twister to say it, you're not medically trained. Prostatectomy, like you mentioned, Mariam, it's either a partial removal or it could also signify a complete removal of the prostate. It's a surgical procedure, so this is not a medical treatment, this is surgical. Now, let's try and break it up into, let's say, open surgery and let's say endoscopic surgery. What do I mean by that? Endoscopic surgery would mean minimally invasive, meaning no cuts on the outside. Basically, we put a camera through the male genital area, through the penis itself, get to the level of the prostate, and via that route, in other words, via the camera with specialized equipment, we can then cut away the inside of the prostate. So you think of it like an apple, and you almost like reaming a core in the middle of that apple to create a channel, to create an opening, so that the person can urinate more freer. So that's what we would do. So in other words, no cuts on the outside. What we call a transurethral resection of the prostate, spelled abbreviated as TURP. Transurethral meaning via the urethra, R for resection, P for prostate, right? So that would be minimally invasive. But that means we could resect the prostate. But obviously that would be a partial removal of the prostate because you only sort of reaming out the core, the inner aspect of the prostate. We're not going there to physically remove the entire prostate. So that would be endoscopic approach, right? If you think about prostatectomy as far as an open procedure is concerned, whether it be with a cut on the abdominal wall below the belly button, whether it be laparoscopic, whether it be even robotic nowadays that is being used, those are means of taking out the prostate entirely. In other words, you take the whole gland out. The prostate gland is between the bladder and the urethra. If you remove the prostate completely, it means you have to suture now part of the bladder to the urethra because now there'll be a space that you've taken something out. So that's the two big groups, endoscopic, meaning partial. Let's say open surgery, which would be more in keeping with a complete removal of the entire prostate.
Mm-hmm. What are the risks involved in having this procedure?
Okay, it does vary depending which technique we're going to use. All right. Now, I must say to you, maybe from the offset, not to create confusion amongst your viewers and your listeners. Generally speaking, if somebody comes to us and they've got a problem urinating and we don't think it's cancerous, but it's a big prostate, in other words, it's interfering with their flow, they have difficulty urinating. The preferred approach in that situation would be to do it endoscopic, meaning camera through the penile area, and we do a partial resection of the prostate. What are the side effects of that situation? complications can happen, like things like infections. People can have a bit of mild moderate pain after the procedure. You can also have frequency and urgency, waking up at night. It can become a bit of a bother for a couple of weeks. But the long-term effects of that can be things like urgency, like urge, where you're going to rush to the toilet and you can't make it in time. They may leak some urine, or urge incontinence. By and large, I would say majority of cases, there's an acute or early stage side effects that most people recover from. The long-term potential ill effects of that kind of procedure would be that the patient may become incontinent, right? But that is not common. That is very, very rare, especially nowadays with the technology that is being used. Not that it can never happen, but it's certainly rarer, you know. I think that's the one thing that bothers men the most, is that if they undergo a procedure and they're going to be incontinent of urine, whether you are a Muslim or a non-Muslim, maybe more so for the Muslim because of the part napat issue. But even if somebody is not a Muslim individual, leaking urine itself is an unpleasant situation, you know. So I think that's the big area. The other big part of it is things like erectile dysfunction, you know, which can also occur following a procedure. It's less common if we do it endoscopic, so in other words, via the urethra, right? If we now contrast that to an open procedure, the main reason for an open procedure, we've got to cut and remove the entire prostate, predominantly, by and large, will be for somebody that has prostate cancer. That's why I want to make that division. So on the one hand, you've got big prostate but not cancer. Then the patient's got an abnormal prostate but it's cancerous. In that case, most often, if you're going to do surgery, it's going to be removal of the entire prostate. What are the potential complications of that? Two big areas. Again, incontinence and also impotence or erectile dysfunction. Right? I must say though that nowadays with technology, with more advanced cameras, with laparoscopic procedures, and also with the use of the robot, especially for cancerous for cancerous prostates, the risk for incontinence has gone down significantly. But the one aspect that still is a bother with surgery, in other words, the removal of the entire prostate, is the risk for impotence or significant erectile dysfunction following that kind of procedure.
All right. And what's the link between prostate cancer and prostatectomy? Are they in any form linked?
Yeah, so as I said to you, if you're making a diagnosis of cancer, right, for whatever happened before, eventually now you've got a patient in front of you, they've got prostate cancer. The ways in which we deal with prostate cancer, one of the ways, I think at some point we did have a discussion on one of your programs, one of your shows, regarding treatment of prostate cancer. And of the modalities that are available to treat prostate cancer, one of them is a surgical removal of the prostate. There are other ways. There's medical therapy, there's hormonal therapy, there's radiation therapy, brachytherapy, there's a whole host of other treatments for another discussion. But to answer your question, if someone has prostate cancer, one of the ways in which we can treat that individual is to surgically remove the entire prostate, is what we call a radical prostatectomy. Radical is meaning it's a reference to the fact that we're doing the surgery because someone has cancer. Right? So that's the link between prostate cancer and prostatectomy.
All right, son. Are there any benefits of this procedure?
Yeah. So I'm gonna answer that question in the context of somebody that has cancer, right? So let's assume we got a patient that has got prostate cancer. We're happy that the cancer is localized to the prostate, doesn't spread anywhere, and more importantly, it's a young patient. In my opinion, in what I do in my practice, because there's so many modalities of treating prostate cancer. If I got somebody who diagnosed with prostate cancer at 65, and somebody who diagnosed with prostate cancer at 45 or 50, the treatment approach that I'm going to take in those two individuals are not the same. So in summary, what I'm saying to you is that a younger individual with prostate cancer, somebody, let's say, under the age of 50, that has prostate cancer, I'll be more inclined to suggest to that individual that let's have the surgery to remove the entire prostate. Why would that be the case? Because that individual, we want to give them a best chance as we can for them to live as long as they want, as the command of Allah will be. But we want to give them a treatment that's going to last them 20 years, So by removing the prostate, removing all of the gland, the long-term effects, 15, 20 years, is better, right? But for example, if somebody is 65, let's say they're 65 and they have prostate cancer, and we do something like brachytherapy or some other form of treatment for that cancer, the patient can live 15 years comfortably. That takes them to 80 years, You see what I'm saying? It's good enough, what I mean? It's not, you can't live forever. But if somebody is 50 and you do the treatment that's only going to probably maybe get them to about 65, that's maybe a bit problematic, what I mean? We want to do something much more longer lasting, more durable, more effects at 15, 20 years in a younger individual. That's why I'm suggesting that in that particular context, I'm more inclined to offer my patients that have prostate cancer at a younger age to have the surgery rather than to go for the other modality. So that would be the link for benefiting that patient in terms of having a radical prostatectomy in the context of prostate cancer in a younger individual. Not to say that we can't operate on an older person. Remember, when we see an individual, we discuss all the options available. Some people, even if they're 65, they have the notion that, look, you know what, I'm the kind of person, I feel like if I've got a cancer, I want the cancer taken out from my body. Some people have this kind of perception. So at the end of the day, the decision of how to treat an individual will be a discussion with the patient and the doctor, and take into account the pros and the cons of each procedure. Remember, if you compare surgery, you're looking at about a 3 or 4 hour procedure, right? You've got to stay in ICU, you've got to have a catheter for about 2 weeks. Brachytherapy, on the other hand, radiation treatment for prostate cancer is a day procedure. There's no cuts on the outside. Patient comes in the morning, goes home the same day. So you can see the difference how you approach them as well. One is a very minimal procedure, one is a much more extensive procedure. So, one is to look at the whole picture. Look at the patient's underlying medical condition. How's their heart? How's their general health? Will they be able to withstand a long anesthetic? Or will they do a minimal procedure but still get a good result in terms of cancer control? So these are, various factors one take into account. And that's why it's not one size fits all, You sit down with the patient and look at all the parameters. As you ask the question now, what are the benefits? The benefits in a younger person and the benefits in an older person, like I explained to you, will not be the same. And so will the disadvantages. For example, in an older person at 65, if they have some degree of erectile dysfunction, may not be such a significant issue as compared to somebody who's 45 or 50 that's experiencing erectile dysfunction. You know what I'm saying? So it varies in that sense.
Right now, what can one expect before the procedure, and how can they prepare themselves for it?
Yeah. So the preparation is both medically and mentally as well. Mentally the patient must be well informed. They must understand what we're going to do. I often find a patient that understands their condition and understands what we're going to do takes away the stress on their mind, and then they're much more easier. So mentally, that kind of preparation is done beforehand. Family support, if they're worried about something, we're trying to alleviate their fears. And then the medical side of preparation involves, as I said to you, we need to know what the patient's heart condition, lung conditions, are they taking any other chronic medication? Do they have any other problems that make anesthesia difficult? So those are all the medical preparation one does before undergoing, especially if we're going to consider a major surgery like removing the entire prostate, or even just generally any kind of anesthetic. If a patient goes to theater for some sort of anesthesia, there's a very important checklist and preparation one is to go through to make sure that the patient is fit enough and well enough to undergo anesthesia and undergo whatever procedure it may be. So those are kind of the preparations, And like I said, from the patient side, remember, they're not medically trained. So we try our best to give them an understanding of the condition. What are we planning to do in theater? What are the short-term ill effects and long-term potential ill effects of surgery? And if you do have ill effects, how we can manage them, So that kind of puts patients' fears at rest. If they get this problem, okay, we find if you have this problem, we can do this to try to correct that. If that arises, we can try to adjust that. This may be a temporary measure. This may be a long-term effect, So I think one addresses all the major issues. And for the patient to be relaxed, they want to know that, okay, that they are confident, they trust the clinician, they trust the doctor, they have a good relationship with the doctor, because that's very important, it's trust. When you go to theater, and you allow yourself to be put to sleep in the presence of your surgeon, your urologist, or whatever it may be, there has to be a level of trust, between those individuals, that while you're asleep, that doctor's going to take care of all the needs. It's going to be there to make sure that you are safe, that you trust them. So that's the first very important thing. And I think that helps to overcome a lot of anxiety and a lot of fear, a lot of unknowns in a patient's mindset. So we go through all of those phases. So as I said, mentally preparing an individual and also medically preparing an individual.
All right, sir. And doctor, going forward, any advice or tips that you can give to our listeners and viewers?
Yeah. So I think whenever we talk about prostate or prostate-related issues, we always want to encourage individuals to understand that they have that control in their hand. Because remember, you could be having symptoms and you could be having problems at home, and you can choose to stay at home. You can just choose to say, no, it will pass. But we always encourage men, at least to have a baseline check, from age 45, if they've got a family history of cancers, or at least from age 50, to have a baseline assessment and a check of their prostate and their general urological functioning. Then we know where they're operating. The clinician will then advise them, I need to see you again in a year's time, I need to see you again in 3 years' time. But I think that kind of responsibility to make sure that I'm doing my regular checks. It's half an hour out of your whole year. It's not a lot of time to ask for, but it may make the difference in terms of picking up conditions and also to treat it well enough. If I can just maybe summarize it in this way, that if we consider prostate cancer, I always tell my patients it's a disease of extremes. In other words, prostate cancer picked up early, the cure is over 95% and maybe better in some cases. So the treatments are phenomenal. Patients recover completely from that. But prostate cancer picked up later is one of the more difficult cancers to treat. So I think that's a very important understanding. If you're having problems, you're having issues, go to your local doctor, go to your GP, get some basic assessment, and find out kind of what is going on. Don't just become complacent and say, you know what. And people are but anxious, they're like, yeah. It's private. I don't want to go and check it out. It's a sensitive area. We understand that. You're right. That is an issue, Or they're afraid to see the urologist because they're going to do a rectal exam to check their prostate, for example, like stuff like that. But I mean, that's a very lame excuse not to go have yourself assessed or not to go have yourself checked when you could be having a problem that can be treated appropriately, So I think that's an important message to get across to men. Definitely.
Yeah, early detection does save lives, and I think men still have this thing of, what, nothing will happen to me, so whatever happens, I'm not going to go for it. I'm not going to go for a checkup, but it's so important. It's for your health, so why not go for a checkup? Why not go for regular checkups? If you feel pain or you don't feel pain, just make sure that you do have a regular checkups. Dr. Choonara, shukran for your time once again and for shedding light on that. There was a question here regarding the differences between a prostatectomy and a radical prostatectomy, but I think you have touched on that earlier. So whoever asked it can just go through the video and they'll find that out. But for now, shukran and have a wonderful day. Assalamu alaikum.
Jazakallah. Walaikum salam wa rahmatullah. Thank you so much.
That was Dr. Salim Choonara taking us through a prostatectomy. What it is a procedure, a surgery to remove a part of or the entire prostate gland. And if you missed out on this, you can view it later on. It is available on YouTube. And share your comments, your thoughts, your suggestions, and your questions. And we'll get Dr. Salim to answer them for us next time. It is 12:22. You are listening to the mid-morning talk on Salam Media with me, Maria Mukwanda. And we have been talking about prostatectomy. I know it's a difficult to pronounce word, but yeah, it is. With some practice, you'll be able to get it. An open or a laparoscopic radical prostatectomy. It is more traditional approach to prostatectomy called an open prostatectomy. The surgeon operates through a single long skin incision or a cut to remove the prostate and nearby tissues. And this type of surgery is done less often than in the past. The radical retropubic prostatectomy, for this open operation, the surgeon makes an incision or cut in your lower abdomen from the belly button down to the pubic bone, and you will either be under general anesthesia or be given spinal or epidural anesthesia. So that answers your question, but you can get Dr. Salim's answer in the video as well. And there it is. You are listening to the Mid Morning Talk with me, Mara Mukwanda. Please stay with us.